and resume the conference. A couple of quick announcements. Again, if you haven't signed in and if you would like to get continuing education credits, you have to sign in every day. So please sign in. And also, if you haven't picked up a bag, we still have some bags over there with a copy of the slides and some handouts. So if you haven't gotten your bag, go ahead and get one. And so I think we have a quorum, so we're going to go ahead and get started. Our next speaker is Dr. Cohen, who comes to us from UC Davis, and who I hear had a very eventful evening. Maybe he'll tell us about it. And he's going to go ahead and talk to us about C. diff.
Dr. Cohen? Please return to class. Thank you for your participation. The drill is over. Please return to class. Thank you for your participation.
Well, hopefully.
The drill is over. Please return to class. Thank you for your participation.
No more. So this woke everybody up. I'm just going to say that I didn't realize that iPhone 17 was released yesterday and that everyone is in the South Bay. A lot of people are here, but it was a little challenging last night, and I doubt I'll be as interesting as Cook, but I will try. And today I'm going to talk about C. diff. I've been doing this for a really long time. We did a lot of C. diff epidemiology in the late 90s and early 2000s, and we've been doing work with diagnostics. I'm sorry to say that I still can't absolutely tell you how to diagnose C. diff, but I'm going to do my best to explain where some of the issues are and how people are working through this. So these are my learning objectives. We'll determine the approaches to make the diagnosis C. diff. We'll talk about treatment, including some of the microbiome-based strategies for treatment, and then briefly on strategies to prevent C. diff in healthcare settings. At least the first two are really high on the minds of administrative people in addition to us as clinicians, because people get penalized when their C. diff rates are high. And I think that this is really made for challenges in trying to optimize diagnostic strategies, because actually people don't want you to optimize diagnostic strategies, because that means the case count is going to go up, and if everybody else isn't doing it, then you're going to end up paying millions of dollars in penalties. So I'm going to just start briefly with some background that most of you are probably well aware of, but just to get everybody on the same page. And then we'll talk briefly about diagnostic testing, and then primary treatment, treatment of recurrent and refractory cases, and then a little bit on prevention. So we're all well aware of the fact that there are more bacteria in our body than eukaryotic cells by about 250 times. And most of these organisms are not cultivatable in a clinical microbiology lab, but they're now all identifiable by next-generation sequencing and other strategies to identify these organisms. And the way that at least the people that work with phylogeny put these organisms together, they talk about them in different classes, but I just want to point out that the gut is a community, that there is a lot going on in the community. And when C. diff was first identified, I think people simplistically sort of thought, well, you know, if you bring back the regular microbiota, it sort of elbows out the C. diff, and there's just no room in the inn, and so they're out of business. But it turns out that when you look at this paper, which is now, almost 15 years old, you can see that the organisms trigger immunologic responses, and those immunologic responses are also helpful in keeping pathogens out. And then they also compete for nutrients and other things that C. diff requires to be able to grow and produce toxins. So it's a big network, and the leaders of the pack I would consider are what we call the firmicutes, which are the gram-positive organisms, including gram-positive anaerobes, including Clostridial species, just not C. diff. And they seem to orchestrate a lot of those responses in the GI tract, and when the firmicutes go down, as well as the gram-negative anaerobes, the Bacteroideaceae, and what I will call the bad organisms, the proteobacteria, which are the E. coli's and the Staph aureuses and the other pathogens, go up, and biometabolism is disturbed, then C. diff can grow, and whether people are colonized coming in or whether they pick it up as a hospital-acquired pathogen, it can ultimately lead to diarrhea and pseudomembranous colitis. So taking that same microbiome picture and then looking at some of the other issues that happen that ultimately lead to the dysbiosis and C. diff infection, I will say firmicutes are our friends. People like that because that is one of those memorization strategies, the 2 F's. Short-chain fatty acids inhibit C. diff spore germination, and so secondary bile acids are good. Primary bile acids actually allow C. diff to germinate and start producing toxin. The proteobacteria are the enemies. Nutrients are provided for C. diff vegetative bacteria, and then once C. diff toxin is produced, it actually inhibits the growth of other bacteria, and it keeps the other organisms from coming back in. And that also is a quorum sensing type thing where the C. diff basically says, we've grown enough, there are enough of us, and now we can start making toxin and change our energy strategy from growth to toxin production. I will also point out, and then I'm going to get into the more clinical stuff, I'm going to point out that all the toxin-producing C. diffs, the so-called toxigenic organisms, they contain a cassette of 5 genes. 2 of them are the toxin genes, toxin A and toxin B. One of them is called TCDE. That's what we call the on switch. TCD, which puts holes in the C. diff that allow the toxin to be released, and then TCDC, which is the off switch. So that cassette is present. That's part of what is identified when people identify C. diff by PCR. They're looking for part of the common antigen that all C. diff contain, so that outside the cassette, and then they're looking for either toxin B gene, or if they look for if they have the epidemiologic cassettes that look for the so-called highly toxigenic variants, they're looking for mutations in the TCDC gene, or the lack of a TCDC gene, so there's no off switch. That's how those tests try to discriminate. they don't show that it's producing toxin. I'll talk about that a little bit more in a minute. So first off, there have been a couple of papers, one from 2021 and then another one that I'm going to show you briefly from 2023 that compare the risks of different antimicrobials prescribed for treatment of clinical outpatient infections. So UTIs, Cipro, trimethylsulfa, and nitrofurantoin were studied in this paper. For pneumonia, moxi, levo, and amoxiclav were studied, and for skin and soft tissue infections, Clinda, cephalexin, and diclox, or cloxacillin, were studied. And then they looked at durations of either none, 5 days, or 7 days. And again, without going into massive detail, I guess I can use this pointer here. Clindamycin is this one that has an adjusted risk of about 3 to 4 times what other antimicrobials do. But you can see moxifloxacin in this study is really close, almost similar. Cipro and levo are a little bit less. They're less active against anaerobes than moxifloxacin is, even though I think there's enough resistance that moxifloxacin isn't really a drug to treat anaerobic infections anymore, at least in my opinion. And then when you look at the drugs that are low risk, you're looking at nitrofurantoin and the tetracycline drugs and trimethoprim and even trimethylsulfa. And this also demonstrates that duration makes a difference, but this is for the 3 different conditions. So this is for UTIs, this is for pneumonia, and this is for skin infections. And you can see that for skin infections, clindamycin is much higher risk. And of course, we all know this, right? This disease was originally called clindamycin diarrhea. So it wasn't really, that really shouldn't be a surprise. And I think, you know, there have been some small studies that suggest that trimethoprim sulfa, and actually a big study that was funded by the NIH and published in the New England Journal, that said that you can treat skin infections without abscesses with trimethoprim sulfa, even though none of us were taught that trimethoprim sulfa has activity against group A strep. And at least in that clinical trial, compared to clindamycin, it didn't seem to be any different. There was no statistical difference, at least. And so people can avoid clindamycin for most of everything, right? And we still see it being used as an alternative for penicillin allergy in surgical prophylaxis. Most of the penicillin allergies, we all are aware, are not real allergies anyhow. And so I think it's something that really needs a little bit more evaluation. And the fact that guidelines are built and probably have to be built solely based on literature, if nobody is going to study anything else, you're left with studies from the 80s and maybe 90s if there's a new drug that somebody wants to get on the market for a particular use. This more recent study was published in Open Forum for Infectious Diseases, and this also compares the antimicrobial risk. Again, these are outpatients, and again, it shows that clindamycin is way off the chart, and the cephalosporins are high as well, and the quinolones sort of fall in a similar order, though Cipro actually looked maybe borderline worse than moxi. Amoxiclav was the worst of the penicillins, and then the tetracyclines and linezolid and macrolides are the lowest risk. So again, maybe telling you something you already know, but that sort of covers it. Again, I think just to point out again, that toxin B is one of the things that we detect in the PCR-based test for C. diff. So let's talk about diagnosis of C. diff. So it's a clinical diagnosis supported by lab data. So that means people need to at least have 3 Bristol stools, 6 or 7 stools, which is water or really close to water, over the course of a 24-hour time period. And if they don't, they shouldn't be tested. That's number one. That makes tests better when you actually use them for a disease process that is a little bit better defined. Second, the toxin testing actually identifies the toxin, which is what's causing the disease, but the EIA test that we use is only about 70–75% sensitive. I'm going to show it on the next slide, but it's an unreadable slide anyhow, so I'm just going to say it. It's only 70–75% sensitive, so it's going to miss some, and that's been one of the problems. Antigen detection will tell you that it's C. diff, but it won't tell you that the organism is carrying the toxin gene, and it surely doesn't tell you that it's producing toxin. So antigen tests and PCRs are identifying the organism. PCR has a leg up because it's a little bit more sensitive than the antigen test, but maybe more importantly, it identifies that at least the toxin B gene is present in addition to the organism itself. We never use stool cultures unless we're doing clinical trials and we're packing stuff away. And then diagnostic imaging. So I don't know why I put colonoscopy under imaging, but that's not routinely done. But everybody with diarrhea and belly pain has a CT scan in the ER before they come up. So they all have colitis, and they're killing me because everybody has colitis. So they all get tested because the CT scan says that their colon is thickened. So this is really a challenge, I think. It doesn't really, it hasn't really been subject to scrutiny. I'm sure it's very sensitive. I'm sure it's very nonspecific. I'm not sure that it necessarily has to trigger testing for everything on the planet. So again, I'm going to just leave this part alone because this is too hard to read. You can look at it in the packet. We did a study because we wanted to ask the question, what happens with patients who have positive PCR tests and who have negative toxin assays? And are those patients, do they really have C. diff? Are we picking up more C. diff by picking up the toxin? This paper was published 10 years ago now, so there have been a number of studies that have looked at similar things. I'm going to just show this briefly. We had a lot of patients that got tested for C. diff, but the group that we really cared about were the ones that were toxin minus and PCR positive, so this 162 patients. And of those, we looked at 121 because they had diarrhea. 41 didn't meet criteria of 3 stools in a 24-hour time period. And then we looked at outcomes. The clinicians didn't see the PCR results, right? They only saw the toxin assay result. So they either treated them empirically with vancomycin or they didn't treat them at all. And we looked at the people who never got treated versus the people who did get treated for a positive test with a positive toxin, or people who had stone cold negative tests. And what we saw was at least the time to resolution of diarrhea overlapped for the people who had negative toxin tests, whether they had a positive PCR or not, and the people who did have a positive toxin assay took longer to resolve their diarrhea. This isn't probably the best endpoint for picking out whether they have disease or not, but you can see the majority of people ended up getting better even without therapy on the same line as people who didn't have C. diff. So we made the argument that that we overdiagnose with PCR and we should be using toxin assays. There are a couple other studies. This one published in CID in 2019 pointed out that the people who had positive toxin assays had more severe disease and higher risks of recurrence, but it didn't say that people who had negative tests didn't have C. diff. And similarly, oops, I got to make this go forward. Similarly, this also showed, this is sort of the breakdown in that study. So, so the 2017 guidelines, which I didn't work on, I worked on the 2010 guidelines. The 2017 guideline basically said don't test unless they meet clinical criteria. And the best performing test would be GDH, which is the antigen assay, and toxin. And then if that's discordant, meaning if you have a positive GDH and a negative toxin, then you reflex it to PCR and use PCR to arbitrate these incongruous results. And then they also reiterated not to test for cure. So that's one of the algorithms. The other algorithms are just being really careful and doing only PCR tests, or reconsidering what you want to do with a discordant toxin assay. So if you follow this algorithm and you do that three-step test, GDH, toxin, reflex to PCR, you will double the number of cases of C. diff that you get, because about a third to a half of the isolates in our lab are discordant. Now, maybe things are wacky in Sacramento, that probably is true, but for different reasons, and so I will just say that that is what we see, right? A third to a half are discordant. So when we started reflexing them, 80% of those are PCR positive. And so we're getting killed. The numbers are going way up. I know all the other UCs. I don't know what Stanford does, but I know all the other UCs. They do PCR, and then they reflex it to toxin assay. And then they say if the toxin assay is negative, it's negative, unless you think it's really positive. And so, we thought, why do the PCR test, right? We have a little lateral flow assay, just like the COVID test that they talked about before. It's easy. It identifies the GDH and toxin. And so we just do that, and this is how we report it now. We report it's either not detected or it is detected and it's positive. And then if they're discordant, we say, call the ID doc, and then see what the ID doc says. Now, the other thing we do, which is unique and we think has been beneficial, and we just wrote a paper that was published in Itchy that wasn't the greatest thing that we've ever written, so I'm not showing it, but I will say that, that we tried looking at our data because we had years and years of getting rectal swabs on people coming into the hospital and then isolating them if they're positive. Not treating them, but isolating them. And then also saying our stewardship people should focus on these folks because they already have C. diff colonization. So the inappropriate antimicrobial use becomes amplified in that patient population. And so, and there have been studies that have shown that lowers rates, and there have been studies that show that it doesn't. We've chosen to continue. So I know the PCR results on everybody because we do what we call a C. diff screening test. So almost everybody has a PCR already. We don't have to reflex anything. And so we have these discussions, often by secure chat, but a lot of times with our voices. We have discussions that say, you know, this is maybe a real case, this really isn't a case. Sometimes if you wait long enough, the diarrhea is already gone. And so I think that it turns out that probably some of these discordants are real cases when I go through the chart, but I also see that people are still getting tested if they're on laxatives or if they're getting tube feeds. And I know that people who are on tube feeds can really get C. diff too, but I think that it requires a little bit more thought. And actually there's a testing pull down in EPIC that tells you don't test these people, and people blow through it, right? Because it's not a hard stop. Nothing in EPIC is a hard stop. So I think this is a challenge, and I think because of the NHSN reporting, people are gaming the system to figure out the way not to identify the most patients, but to identify the least patients. Right? I've seen things on these ID chat boards that I don't look at very much, but sometimes I do. And when I looked at it, it said, you know, our hospital administrator just says if they have diarrhea, just treat them. Don't bother to test them. So, right, so they have rates of 0. So if you're really trying to do it right, you're going to get killed by these guys. And I think, and it costs a lot of money, and that puts a lot of pressure on ID docs who are making these decisions. And so, so not to say that you shouldn't put pressure on us, but we can only control what we can control. And I think, again, I think this is really a challenging area. And I think that we do a lot of finessing, and maybe that's the right way to practice medicine in general, right? That we don't have a test for every single thing. But I think it's an important thing for people to understand, because I think that's the strategy is PCR first, toxin assay negative, this is a negative test, or this is a discordant test, probably doesn't need treatment. So I'll get off that. Right. I'm old, but I still, well, maybe I'm getting more demented. Maybe that's part of this. But I really have still pretty strong opinions about this stuff, and some of it I wear a little bit too much on my sleeve. What about resistance, right? People talk about drug resistance. This, again, I have 2 papers that I put side by side. One is from 2017, the other one is from 2024. This requires doing cultures, so this is all European data. There's nothing from the US that I've ever seen. And there's no fidaxomicin resistance. There's basically no vancomycin resistance. Are the breakpoints right? An MIC of 4 for vancomycin when the concentrations of vanco in the stool are about 3,000 per gram of stool. I'm not sure that if it's 8 that it's really resistant, but maybe it is, and there aren't really tests to support that. Where the problem is real is with metronidazole, where the rates of resistance are about 4%, and about 8% of them are considered intermediate. And metronidazole leaks through an inflamed bowel. It's fully absorbed before it gets to the colon. So what gets to the colon leaks in. So those numbers actually matter. That's tissue penetration rather than just pass-through drug like you see with fidaxomicin and vanco that are not absorbed. The rifamycin, the resistance rate is has gone up from 17% to nothing. Moxie and Clinda, there's a lot of resistance. That's why you see these organisms or these drugs as the highest risk for getting C. diff, and meropenem, no resistance. So metronidazole resistance actually is associated with treatment failure. That would be predictable because of the way it works. And then this was a study that was published 3 years ago. It was done in Houston and in Kenya, and they looked at 25 isolates that were not susceptible to vancomycin. MIC was greater than or equal to 4, so we don't know how high the MIC actually was. And a mouse model was used to test whether resistance was associated with failure or failure to eradicate the pathogen. And what you can see from the pie charts, Houston is on the left, Nairobi is on the right. You have a really high rate of vancomycin resistance in Nairobi, Kenya, and relatively low rates in Texas. And as the MICs go up, the number of patients that don't, or the number of mice that don't respond as well to therapy goes up as well. And so I think that's been the challenge is, again, we don't use we don't really do the dilutions all the way out to see that the MIC is infinity rather than 4. And so I think we can't really make much sense of it, and so susceptibilities really aren't necessary. But some of those people that fail probably do have resistant organisms. And this is a paper from last year that also suggested that it was an independent predictor of failure. Response rate going down from 96% to 89%, so still really high rates of response, but not super high. This is the treatment guideline. Again, another slide that should have been typed out, but due to laziness didn't get typed out, and so you can read this in your spare time. But I think what happened is in the update that was done in 2021, they really have been emphasizing the use of fidaxomicin as a preferred agent, primarily because of the lower rates of recurrence, because fidaxomicin is much gentler to the normal gut microbiota. And so that's been part of the push. Fidaxomicin is still more expensive than vancomycin, and so still most facilities are using vanco predominantly, and fidaxomicin for patients that have failed once or people who are not responding quickly to vancomycin. This is a meta-analysis that probably is not relevant anymore because I don't see much metronidazole use anymore, but metronidazole is clearly inferior to vancomycin. So, so this was the update. Simple answer, yes. In patients with recurrent episodes, should fidaxomicin be used rather than vanco? Yes. Standard or pulsed regimen. Vanco taper was also considered an option, and multiple recurrences, FMT or other microbiota-based regimens would be preferred. So, so I think that pulse taper thing with fidaxomicin, that paper, which was published in Lancet Infectious Diseases, has always bugged me because they did pulse taper with fidaxomicin. They didn't compare it to pulse taper with vancomycin. They compared it to a 10-day course of vancomycin. And so I didn't feel like it was set up in a design that was really to determine the optimal pulse taper strategy. It was really designed to show that that's an option, and it wasn't even clear that it was that much better than just a 10-day course of fidaxomicin. So this is that paper, and as I say, it struck me that this was a 25-day course of extended pulse taper with fidaxomicin, and then vancomycin was given for 10 days. And clearly, if you look at the bars, the recurrence rates with vancomycin are significantly higher than they are with fidaxomicin, anywhere from 3 to 10 times higher. This paper looked at use of exogenous antibodies and recurrences, or endogenous antibodies and recurrences. This group at Harvard has studied this over the years. They've demonstrated that presence of antibodies and a good antibody response is associated with a lower rate of recurrences. They initially focused on toxin A, but I think animal studies suggest that toxin B is the more important of the two toxins, and so they've looked at that as well and demonstrate that recurrence rate is lower when you get antibodies. And so people were using bezlotuximab to treat some of the recurrences. The original clinical trial with bezlotuximab was used in part of the primary therapy and demonstrated that there were lower recurrence rates if they got bezlo. But bezlo isn't available anymore unless you've got some residual vials left in your pharmacy. But once those are gone, it's gone. And so antibody therapy right now is not an option. AstraZeneca has an antibody therapy that they are just starting to roll out studies that may or may not replace bezlotuximab. There's not much data to say one way or another yet. The other question is, what about use of probiotics when people are on antimicrobials? This to me has always been challenging because these meta-analyses include lactobacillus and Saccharomyces and everything else all lumped into probiotics, right? You can't do that. I don't see how you can do that. You can't lump fluoroquinolones and cephalosporins and say antibiotics work. And I think it's always challenged me. I think that what some of these studies suggest is that since they're not regulated, at least the these over-the-counter products are considered food supplements, so they're not really regulated in the same way that drugs are. And so you don't know whether you're getting the same thing every time you buy even the same brand and the same number of organisms. And so I think that's why it's mixed. I always tell people it doesn't hurt them. Unless they don't have any white cells, it doesn't hurt them. And so they're welcome to take them, but I don't think that this is really a strategy. I think this has been sort of the way that people have gone forward, and the idea is just to get back to healthy microbiota. And the first large study that was published also came out over 10 years ago in the New England Journal of Medicine. It got people excited, and people started doing FMT in their offices. GI guys started doing it by colonoscopy. Some people did it by NG tubes until somebody aspirated and ended up getting extremely ill, and so that sort of went away. And I think now we have better ways to deliver microbiota than buying stool from a stool bank. This just showed that that enema worked better than vancomycin taper in patients that had multiple recurrences. And this is a paper from a GI journal that also shows a significant benefit over both fidaxomicin or vancomycin. And so this drug now is called Vowst, is the trade name. I'm sorry, I don't use trade names, but I don't know really what the real name is. They make it pretty hard to figure it out. And this is oral firmicutes. It's collected from normal donors. It's processed into a capsule or a tablet, and the patients take some mag citrate to clean out all the residual vancomycin and clean out everything else, and then they take the medication, and the response rates have been terrific. And so I think it's one way to do it. There's also a medication, also trade name is Rebiota, that can be done by enema. We do them in our ID clinic. Patients usually prefer these tablets, but if they want to transplant, quote unquote, for real, we do the enemas in our clinic. We've had really good results on a anecdotal basis. And so I think this, though, was a randomized trial of efficacy and safety of FMT for prevention of C. diff in the VA. It was oral FMT capsules versus placebos. The capsules were manufactured at the University of Minnesota. The endpoint was clinical recurrence at 56 days. There are 153 participants, older patients, and the recurrence rate in the FMT arm was modestly lower than the placebo arm, not statistically different. They stopped the trial. So I think, you know, there obviously are negatives. Not everybody is going to respond to everything, but I think most of the time patients will respond to one of these microbiome therapies, which makes sense because if the problem is dysbiosis, then fixing that is the right way to address this in my estimation. I'm not going to show this because timeline is running out and it's too complicated. And then two last slides, 3 studies with prophylaxis with vancomycin. This is also a challenging area, but I think people who are high risk sometimes get extended, like our BMT patients, after they treat them for C. diff, they end up staying on vancomycin while they're getting antibiotics. It seems to work. I think that the data aren't totally clear. I think for high-risk populations, it probably makes a certain amount of sense. And then these are what I call the pillars of C. diff prevention: stewardship, rapid identification, at least, of people who are colonized, hand hygiene, which means soap and water, right? So spores aren't killed by alcohol. Soap and water gets it off because you rub them off and they go down the sink. So it doesn't even have to be antimicrobial soap to get rid of it, to be honest. And then good cleaning practices in the hospital. That's, I'm sure, a challenge everywhere because people are trying to save money by limiting the maintenance staff. And then clinical decision support for actually doing the diagnostic testing. And I will stop, and I think I was close to on time. I got the, please conclude your presentation, so thumbs up. Any questions or comments? I always try to get too much into these talks. I apologize if it was a little bit cluttered, but I'm happy to answer any questions that anybody might have.
Thank you. Great talk, Stuart. Kim Ehrlich, Mills Peninsula. One of the issues we come in to have to face repeatedly is isolation in the hospital. So a patient, say, who has a discordant C. diff test, maybe the GDH is positive, the toxin's negative, maybe a decision has been made to treat with oral vancomycin or not. They're having diarrhea. How long do they need to stay in isolation, and what are the criteria for getting them out of isolation in the hospital?
Boy, that's a really good question, right? Because we do this on our own, right? So if you come into the and are admitted to our hospital, you're given the option of opting out, but you're asked whether it's okay to do a rectal swab for C. diff testing. And if you're positive, you're isolated, and you're isolated for the duration of your hospitalization. And so we've tried to manage the discordance the same way. That's really unpleasant for people, and I think that it really needs to be reevaluated, particularly if they're truly discordant. But they are, I mean, they are colonized, and as I say, 80% of those are going to be colonized with toxigenic C. diff, and so since it's our policy, that's what we would do. I think in other facilities, they probably don't even isolate them when it's discordant, and if they don't have active diarrhea, people will take patients out of isolation too. I think that's one of the other strategies is when the diarrhea is gone for 48 hours, you can pull them. And if they're discordant and they have diarrhea, you can use the same criteria. Right. We would keep them in for the duration.
Yeah, no, that's kind of what we do, is we wait till the diarrhea is resolved, and then once they're moved into a new room, then we can take them out of isolation. But we assume the room is contaminated, and so even if the diarrhea is resolved, if they're still in that same room, we keep them in isolation.
Yeah. I think that's a good idea.
Hi, Dr. Cohen over here. Grace Hasid from San Mateo Medical Center. Thank you so much for being here. And your talk is really timely and helpful. I feel your pain as the infection control person for the, our hospitals and clinics. We deal with this issue of the reporting, surveillance criteria, which also, in my estimation, is really faulted by being 3 days, meaning If a patient doesn't have a stool test within, this is a little bit opposite of over-testing, but if the stool is collected after 3 days, it's considered hospital acquired. And meanwhile, the patient has a 2-week history of continuous diarrhea, and this diarrhea has nothing to do with our facility, but the stool was not collected in a timely way, so we are dinged as having caused this diarrhea. And to me, it's a failure of the because often, especially our patients, we take care of the uninsured and people with a lot of challenges socioeconomically, and they may have diarrhea for weeks before they come in. So they're coming in kind of on the tail end. They may not even produce stool initially. They're so dehydrated. They literally are. They have, tenting of their skin, and they are truly dehydrated. And then as they are rehydrated, then they produce stool. It's diarrheal, and we test it, but now we're blamed for the infection. So I think, there's so many issues, and you're right. I do think some, institutions are gaming the system, and then surveillance criteria are not correct, so it's very frustrating.
Yeah.
That being said, C. diff is 500,000 people a year in the U.S. have C. diff. 30,000 people die from this, and untreated, undiagnosed, untreated. So it's a conundrum of overdiagnosing, diagnosing in time, underdiagnosing, and in terms of removing from isolation, I mean, I agree with you. We do not take people out of isolation if they've been diagnosed with true C. diff, because we know they're shedding their spores. Even though diarrhea does stop, they're still shedding. So, and it's about, do you trust your environmental services to do a supreme job? And in general, we have great environmental services, but it's a conundrum. There's a lot of areas that things can go wrong along the way. And antibiotic stewardship is at the heart of everything, trying to give the right antibiotic for the right amount of time, not over prescribing, not over broadening, et cetera, et cetera. So, but thank you for being here. This is really helpful.
Yeah. And I would just make 2 quick comments in relationship to that, because I agree with everything you say. One thing that we did do a number of years ago, and one of my colleagues presented a paper at ID Week, and he never wrote it up, we find a handful of people that have C. diff when they come in with diarrhea, and our argument has been that if you order a GI panel, you should order a C. diff diagnostic test on somebody coming in with diarrhea. If you're not going to test them, they don't need a C. diff test, but if you're going to test them, you might as well test them. And so we pick up some that come in with it, and so we don't get clipped as much by that 72-hour thing. The second thing is that CDC has been trying to pilot this idea that people will only count with they're going to move it from a lab-based diagnosis to a clinical diagnosis, which says that if patients haven't received 3 days of antimicrobials specifically targeting C. diff, that it isn't really C. diff. God knows when that's going to roll out and whether it ever does, given, first of all, that it was slow to start with, but now it's going to just be slower. And so I think that that is definitely a challenge. So, yeah, we can commiserate.
Dr. Cohen, I'm Jamila Chamsi from Kaiser, South San Francisco. Great talk. Has there been any more work done on primary and secondary prophylaxis for C. diff, or is it just the small studies?
Yeah. So there was actually a reasonable sized study with primary prophylaxis in BMT patients. And there was a statistically positive benefit. It just was modest, and so people never really adopted it. I think that there have been other studies. The VA, I think, is doing a study with secondary prophylaxis. that's going to be big enough to be able to actually make sense of the data. There also, I think, should be a paper. It's either out or it will be out in JAMA Network Open that also looked at secondary prophylaxis that was pretty well done and I think demonstrated some benefits. So I think it's not for everybody, but I think for targeted groups it makes sense. And I'm sort of was against it to start with, but I'm getting a little bit warmer.
Dr. Cohen, great talk. Thank you so much. When I did my fellowship, C. diff was basically a hospital-acquired infection. We seem to see in our hospital more and more people coming in with C. diff that don't have typical risk factors, that weren't exposed to antibiotics. Can you elaborate? Is there something going on that we haven't figured out on the organism? Is this something that is new?
Yeah, I think that's really a good point. There have been some papers published from CDC on community-acquired C. diff, and as you say, a lot of the patients haven't received antibiotics before. That's why testing in the ER for somebody with diarrhea makes sense, and they're not all elderly patients as well. There are some younger people. Presumably they pick it up from either colonized relatives or somebody else. But why they end up with the dysbiotic GI tract to be able to come down with disease is not clear, and I don't think that those data are available. They're surely not in my knowledge base. Okay. Well, thank you very much. Appreciate your attention.